guys have heard it once, twice, then you're going to hear it 1,000 times. The SLO or your student learning outcomes, and they guide your learning. That's what your tests are based on, and that's how you should study.
Is this recorded?
Yeah. I'm going to record it. Yes, ma'am.
Thank you kindly.
No problem. Wait, did I record it yet?
Recording in progress.
I'm coming, guys. So today we're going to discuss assessments. More importantly, we're going to discuss abnormal assessments. You guys have probably learned how to do a head-to-toe assessments in level 1, which is great because you need to know normal assessments before you could start recognizing abnormals. So this is, of course, the first part of the nursing process. This is the first phase, assessments. And it's going to take time for you guys to learn how to do a thorough assessment, but we're going to start here. And along with assessment, once we recognize that someone has an abnormal assessment, we need to know what are we doing about it, what nursing interventions needs to be done immediately. So that's what we'll be going through. We'll discuss some anatomical landmarks for assessing patients. For the neurological system, the cardiovascular system, the neurovascular, and the respiratory system. So we'll discuss landmarks, then we'll discuss subjective and objective data, and once we find those abnormalities, how does the nurse approach the treatment of those patients? So the neurological system is divided into 2 parts. You have your central nervous system and your peripheral nervous system. We're not going to do a whole lot of patho, because your tests are all going to be nursing process based. What do you do for the patient? How do you know if your treatment works? So that's how tests are going to be based on your SLOs. So you're not going to see patho on examinations. And the neurological system, it regulates all your body functions, muscle movement, senses, mental abilities, and emotions. And the parts of the neurological assessment that we're going to cover is the mental status, your nerves, motor function, sensory function, and reflexes. So we'll start with the mental status. These assessments can obtain just by looking at your patient and talking to your patients. You don't have to do anything else besides look. You could assess their appearance, the dress, how they dress. Are they disheveled? Are they clean? Are they, smelling? Then when they walked in, was their gait steady? How's their posture? So you could tell a lot about a patient's mental status just by observation. And you could also assess their behavior. Are they speaking fast? Are they speaking low? Are they yelling or screaming? So we could assess behavior, again, just by observation. And there's a tool that you use. It's called the Glasgow Coma Scale. Have you all ever used that? And it measures the level of consciousness of a patient. Has anyone ever seen the Glasgow Coma Scale, the GCS scale?
We covered it last semester.
Good deal. So make sure you know it because you'll see it again this semester. And under what circumstances would you use this scale?
Stroke patient,
unconscious patient.
Admission.
Yep, trauma patients, we use it a lot in the ER. We use this scale, admissions. So make sure you know how to use the Glasgow Coma Scale because you may see it again. And the decorticate and the cerebral, that's new since I worked in the ER. That must have just been added to the scale. So make sure you know that. And another thing, when you're assessing their cognitive function and you're asking them about and you're assessing their alertness, the AAO ×3, remember that? Awake
Alert oriented times 3.
times 3. So when you're documenting, do you want to document just awake, alert, and oriented times 2? Like which 2 are they oriented to? So you have to be specific in your documentation so that everyone can be clear about what this patient is oriented to. So you might say awake, alert, and oriented to place and time, and unclear about, person. Doesn't really know who they are. So just be clear in your documentation. And speaking of documentation, I'm an old nurse, and we did narrative notes. We did paper charting, and we would often see notes. I'm pretty sure my older colleagues know about these nursing notes. It'll just be awake, alert, and report received, care assumed of patient. Patient awake, alert, oriented time 3. Respirations even and unlabored. Everything's normal. Everything was normal. So that's just not the case. That narrative is just not true. But we wrote that out like it was the gospel truth. When you do your narratives, because my clinical group has to do one every day, make sure you put in truthful statements in that narrative. All right. And also included with your neurological system assessment is going to be your cranial nerve assessment. I'm not going to go through each and every one of the cranial nerves, but you should know them, how to assess them, and under what circumstances you'll assess them. And there's a good chart, and it tells you when it's abnormal, what's the problem, how to assess it. That's just more cranial nerves. So how do you assess the motor function?
The whole touch your nose and following the, can you put your arms out, abduction, adduction, circular motions, all that good stuff.
All of that good stuff. So what is that giving you information regarding?
Their range of motion.
So it's giving you information regarding their neurological status.
Yes.
Yes, it's giving you information regarding their neurological status. And some of it you can notice just by, again, assessment. When patients walk in the room, do they have a steady gait? Do they have a shuffling gait? Do they hold on to the wall while they're walking? All of those give you cues that maybe something is going on with this patient neurologically, right? If someone has a shuffling gait or they not balanced, what would the nurse do? This is where we jump in. What do we do? What do we need to do for that patient?
Make sure.
We need to provide for the safety, right? So we have to remember that, provide for safety. And you may, you check the motor tone of the patient, and you check the hand grips. You'll see people do that, squeeze in, have the patient squeeze their 2 fingers to check their hand grips, and balance and coordination. And what disease processes do you think you may find some of these abnormalities? Involuntary movements, tremors,
Parkinson's,
stroke, MS, stroke.
Some of your psych medications may cause it as well.
Okay.
Would vertigo be considered because they can't, walk it straight and all that good stuff?
Yeah, so it'll mess with their balance and their coordination. Right. And so there's the Romberg test when you're standing with your feet together, eyes closed, and you should be able to maintain your balance. If your balance isn't maintained, then you have a central nervous system or peripheral nervous system issue. And there's also another test that you'll see when you are working in hospitals or ERs or stroke units. There's going to be an NIHSS scale. And that's a scale that does these neural assessments for patients. And what you do is, it's a long list, it's a checkoff list, but you're going to be checking GCS, you'll be checking pupils just to check their status. So you always want to get a baseline. because the next nurse might check. So you want a baseline so you can know if things are getting better or not getting better, right? So you always need baseline vitals, baselines neural assessment, baseline cardiac assessments. You always have to get a baseline to compare things to, because the goal is to make sure that people are getting better. And another order you may see is neural checks, right? Anyone has seen neural checks, Q2 hours?
Yes.
Or Q 15 minutes for 30 minutes, and then it may go to 2 hours.
Yes.
And under what circumstance did you see that?
A head injury.
If you work in a nursing home and a patient falls and hit their head, but they're
Brain cancer.
brain cancer. And why are you doing these neural checks?
To check the level of consciousness.
Changes. To see if there's any changes in their answers from 1 hour to the next, if there's brain swelling or.
Yeah, so you anticipate that they'll get better, but if it progresses, then we need to start doing some other things. Very good. So what tests do you think, what diagnostic tests will be used in the assessment of neurological?
MRI.
MRIs, checking the spine.
Intracranial pressure.
So, yeah, so you'll do a CAT scan. And that's going to be a huge one because, and I'm not going to even talk about specific disease processes, because this is just kind of helping set you up for your other concepts that you'll get later on, the perfusion concept, the oxygenation concept. So this is just kind of getting you to understand that you need to learn how to recognize abnormal assessments. And when you recognize the assessments, what do you do with them? Do you just document it?
No, you bring it to the physician.
So you get the baseline of the patient.
So if you're assessing these patients and you're noticing that they're having memory issues or they're having judgment issues or agitated, depressed, we need to escalate it. If it hasn't been documented or addressed, we need to escalate it, right? We need to let the doctor know, the provider know. We can't just have abnormal assessments and move on. So we have to let the appropriate people know what's going on. All right. And this is another function of the assessment system is sensation. So what are we assessing with touch? Like, what will we notice? What are we looking for?
Do they have any? They feel it and their brain's connecting to their feeling.
Decrease in sensation, coolness to the skin, temperature.
They're looking for a response to stimuli.
Yeah, so we want to make sure that the patient can differentiate between soft and sharp or dull, and they should be able to differentiate between different vibrations. And when we do this test, we can use a cotton swab, we can use something sharp like a pen, or we can use something dull like a little paper clip, and you want both sides to be equal. You want them to feel, if they feel it on one side, they should be able to feel it on the other side, right? And this sensation may be impaired if a patient has a stroke, it may be impaired. They may have numbness, and also spinal cord injuries, right? And brain tumors. And you're not, like, when you're doing regular everyday assessments, you're not going to be doing like full neurological assessments, like, unless it's a focus assessment, unless your patient does have a stroke, and we need to be monitoring whether or not they're getting better, worse, or the same. Unless your patient does have a brain tumor and they're receiving treatment, and we need to do these full assessments to make sure they're getting better. But on your average everyday persons, we're not going to be doing these full assessments. You're not going to be pulling out cotton swabs or sharp or dull objects and testing patients every day. That's just not what you're going to do. When you go to clinic with your instructor, I'm quite sure they won't expect this. So this is not done on everybody, and it's always going to be situational. All patients are different and they require different things, but if they have a neurological issue, you may be doing all of these things. Even your Q2-hour neuro check, it may include different things. Sometimes it's just pupils, it's just are they awake and alert, their level of consciousness, hand grips. If they have strokes, you may be doing that whole NIHSS scale every day. So it just depends on what the doctor ordered, what's necessary for the patient. And again, the position, that's when you the patients put their finger, move the patient's finger or big toe up and down, and they need to be able to tell you what you're doing. And if they can't tell you what you're doing, it's probably a spinal cord injury. So all these neurological issues are either brain injuries or there are spinal issues. Any questions so far? And if I'm talking fast, just ask me to slow down. I'm trying to work on slowing down.
Ms. Cloud, just explain about the position.
I'm sorry?
What's the other assessment that you say? You say NISH scale?
So that you won't be tested on that. I'm just letting you know, like that is, so stroke is dealing with the brain, and you'll have these pronated drifts with stroke sometimes, or sometimes you'll have like decreased strength in one hand versus the other. And so there's a scale that they do in the hospitals. Yeah, it's NIHSS. That's just some extra information. When you're doing assessments, you do want to develop a systematic approach to these assessments because you don't want to miss things. And when you start working in your novice nurse, it's just going to take time, to get these assessments down. And always, always, always do these assessments on your family members. Do them on your friends. So the more practice you get, the more progress you'll make with them. So make sure you know your central nervous, your cranial nerves, how to assess mental function. Yeah, I went over the Glasgow Coma scale last semester. That's good. Make sure that you know it. Any questions about sensory? And next we'll have our reflexes. So these reflexes.
Quick question.
Yes.
Can you go back to the Glasgow Coma scale slide real quick? Okay, thank you. I was looking at the comatose says 8 or less. For some reason, I thought it was 6 last semester that we learned.
Did you learn 6? I'll look that up. Thank you. Just put it in a discussion board so I can review it and just make sure I'll give you the right information. Thank you.
Thanks.
Don't forget to put it for me, okay, Miss Elizabeth?
No problem.
Thank you. So with these reflexes, the Brudzinski and the Koenig, they're both testing for meningeal irritation. If they're positive, you have meningeal irritation. And that's the doctor will treat that however they deem necessary. We just assess and report the findings to the appropriate people and assess for the abnormal postures of unconscious patient. And I learned a long time ago, when you think about the cerebit, they're celebrating, how you're a cheerleading doing this. So they'll have that outward movement. And the corticate posturing, they'll kind of be stiff and rigid toward the center of their bodies. And that's when you have like severe brain injury. You probably won't come back from that.
What were those a positive sign of?
Brain injury.
Brain injury.
Probably, they don't usually make it back to normal after these abnormal posturings. Any questions about the neurological system? And the persons you'll collaborate with. You probably, if someone has speech issues or ambulation issues or paralysis on one side of their arm or legs, you'll probably, what what services you think that patient will need?
Physical therapy.
Physical therapy,
Physical
Speech therapy.
occupational therapy.
I can't think of it. Is it the speech when they learn how to swallow and
speech. So occupational occupational speech, PT, all of those therapies will probably be on board with caring for this patient so they can reach their ultimate goal. Their ultimate goal is to get them to the ultimate level of function, whatever that'll be for their circumstance.
Can I ask a quick question about the Brudzinski sign and the Kerrigan sign? So are those only done if they're unconscious? Is that what you said at the bottom? Or
No,
you can't?
They have to be able to participate in that because they need to flex their knees. No.
Okay, so what was
the abnormal?
Sorry, go ahead.
The abnormal posturing?
Yeah, just the last slide.
Yeah, so it's the abnormal posturing. That doesn't have anything to do with the Brudzinski. And I don't know why I put it on this slide, but yeah, that's just abnormal posturing.
Okay, thank you.
Barrett and a decorticate, which is severe brain injury, and they usually don't come back from that. But those other two signs are totally different.
Okay, thank you.
No problem.
I don't mean to interrupt. I just want to make sure I'm in the right place. Was this the 9:45 class?
Yes.
Okay, we started early.
Yes, ma'am.
Okay.
All right. Any other questions? If you think of something, just put it in the discussion box and put that Glasgow Coma scale in the question in the discussion box so everybody can be clear. The discussion board, so everybody can be on the same page. Thank you, Miss Elizabeth, again. All right, so now we're going to move on to the respiratory system assessments. And this system the function is to obtain oxygen from the atmospheric air and transport this through the respiratory tract into the alveoli and ultimately diffuse oxygen into the blood to carry oxygen to the cells. And when this does not happen, we're going to have some respiratory signs and some respiratory issues. So I just gave you a picture of the anatomy of the respiratory system. So when you talk about the upper respiratory and the lower respiratory system, you can get an idea of what we're talking about. Because some abnormal sounds are specific to the upper respiratory tract and some the lower. Lines and landmarks. So the angle of Lewis, which is the sternal angle, is a useful place to start counting the ribs. It marks the bifurcation of the trachea into the right and main bronchi. So what can you tell me about the lungs? What's significant about the lungs?
They aid in gas exchange.
They expand and contract.
They do. And so what's different about
the right side is wider than the left side?
Right side has 3 lobes, left side has 3
lobes, and left side has 2.
That's
without surfactant, it can't do its job.
Okay. But yeah, more specifically, I was thinking about the right side has 3 lobes and the left side has 2 lobes. And why is that? Why does the left side have 2 lobes, you think?
Because of the heart.
It's smaller.
Because the heart is positioned there.
Because the heart is positioned there. That is correct. So it makes a difference in your assessment, right?
Yes.
Because the left side only has 2 lobes. So we talked about in order to be able to distinguish normal from abnormal, you have to be very proficient in knowing what the normal breath sounds are. So you have the bronchial sounds, the bronchovesicular sounds, and the vesicular soft sounds. And so when you're about to assess a patient, what considerations, like when you're about to do a respiratory assessment, what do we need to do? How are we assessing this patient? What's the procedure for performing a respiratory assessment on a patient.
Have them sitting up so you can get both anterior and posterior access to listen.
Yep. So you want to have them sit up. That's the best way to assess the lung sounds.
Make sure they're at rest.
Okay, making sure they're at rest.
Make sure that you compare each lung, like the symmetry and equality.
Yep. You want to make sure you're comparing, and you want to also provide for privacy for this patient, right? Providing for their privacy. You want to always wash your hands. So these are things that you have to remember to do all the time. And it's so basic, but it's so important. You want to make sure you wash your hands. You want to make sure that you explain to them what you're about to do. You explain to them what you need them to do for you. You need them to breathe through their mouth and take deep breaths. And you're gonna move the stethoscope from right to left just to let them know what's about to happen. And if it's a female, do you want to auscultate through the breast or no? You want to lift the breast so that you could hear the breath sounds. So you don't want to go through tissue. What's some other things that need to happen? Do you want to listen over clothing?
No.
And why don't you want to listen over clothing?
Because you're going to get the average sounds, different sounds you're not going to be able to, it's going to be like crackling noises against the clothing. Rubbing.
Exactly. So you want to make sure all of these things are in place so that you can get the best assessment that you can get for this patient. And when you listen posteriorly, what do you need to do? So we can go back to landmarks. So anteriorly, where do you start listening to the breath sounds? What are your landmarks? Where are we starting?
At the trachea?
Trachea, second intercostal space, the fourth intercostal space, 6, 8, and then the back is 3, 6, 9. We're starting like going like an 8, like an A shape.
Okay. So where do you listen to the apex of the lungs?
Vesicular. Yeah.
Right above
on the right side.
The fifth intercostal space.
6.
Okay. So you guys are right. So when you're taking these breath sounds, so you start above the trachea, then you do the right above the clavicle. And what sounds do you hear right above the clavicle?
Bronchial, huh?
Bronchial. Should you hear that? And should you hear the bronchial sounds posteriorly?
No.
No.
What happened to my board? Yes, so you should not. And if you do, there's an issue. They say maybe some consolidation back there, but you should not hear the bronchial sounds posteriorly. And so where do you place your stethoscope when you're listening posteriorly?
Between the scapula and the
scapula, like follow the scapular line, the midline of the scapula.
The scapula and the spine. So you might have them open up their back a little bit so you could get to those spaces. Very good. And this is just your normal breath sounds and where they're located. So when things aren't normal, we come into abnormal breath sounds, and this is what we're going to start paying attention to. This is what we need to recognize. We need to recognize why we're getting adventitious breath sounds and what's the probable cause. How is it treated? How do we know these patients are getting better? Right? So this is what we're going to do all semester long. What's the signs and symptoms? Or you'll start hearing words called cues. And it's very similar to the nursing process, but it's called a clinical judgment model. In my group, we're going to do the clinical judgment model the entire semester. We're going to recognize cues, which are essentially signs and symptoms. What cues do you recognize? Why are they significant? And what information was less important or distracting. Then once you recognize the cues, you want to analyze the cues. What findings do you expect? What is concerning? What is contradictory? And then you're going to hypothesize what is most likely occurring. So if you have a patient with wheezing, what might you see? I mean, with asthma, you may see them wheezing, you may see them like in a postured position so they can expand their lungs. You may see them coughing. So all of those are cues. Now, what do you expect? You expect that they may have wheezing. You might expect that they may have asthma. They could have bronchitis. So what are we going to do? What are some desired outcomes? And so that's how we're going to look at this whole semester. What's going on? What's probably going on? What can we do about it? We're going to generate some solutions and take action and then evaluate the outcomes. It's just like it's essentially the nursing process with that added piece, which is the general hypothesis. That means, what do you think is going on? If someone has shortness of breath, what could be going on? They could have asthma, they could have CHF, they could have pneumonia. So all of those things are what they could have. And it's like a differential. But we'll get more into that, and you'll probably see your instructors introducing you to that more and more. And it is used to help increase your critical thinking, because studies are saying that novice nurses are getting out of school and they have really poor critical thinking skills. So this is to kind of help you start thinking more and acting. All right, so some adventitious breath sounds are just essentially abnormal breath sounds. And this is a list of the breath sounds that we will go over today. So we know our landmarks, we know how to assess, we know how to prepare the patient for the assessments. So now we're going to see crackles. So what can be producing crackles?
What was that?
Fluid.
Fluid.
Mucus.
And you may see crackles a lot in patients with CHF. And another thing, when you're assessing patients and they have a history of maybe CHF or COPD or pneumonia, and they're giving you very poor effort, you may want to start in their posterior bases to get a better feel for what's going on with them. Okay, back to crackles. They're high-pitched popping sounds. And so there's fine crackles and there's coarse crackles. Does anyone know the difference between the two? Have you had a chance to review that?
No, ma'am.
So fine crackles is more like when you take your hair and you like rub it next to your ear. That's kind of like what fine crackles are, and they're high-pitched popping sounds.
And this would be like pulling sound, like it sounds like when you're pulling Velcro apart.
The coarse crackles sounds like when you're pulling Velcro apart. And you might see that with CHF, pulmonary edema, asthma, and respiratory distress. You may get those coarse crackles. And they're formerly known as rails. And what other condition could cause crackles?
COPD or pneumonia?
They are
When did it stop being rails?
So atelectasis.
Atelectasis.
Yes, atelectasis, very good. It's the collapse of all or part of the lungs affecting the exchange of O2 and CO2. So atelectasis.
Excuse me, can you repeat what coarse is?
Coarse crackles are low pitched, and it sounds like Velcro or pouring water. And that's usually associated with CHF, pulmonary edema, asthma, and respiratory distress. And they're audible at the posterior lower bases. That's probably where you'll hear crackles. So if this is retained fluid, what do we need to do for these patients?
Diuretics.
Diuretics, we need to diurese them. And how do we know if our treatment is working.
Weigh them.
Edema goes down. You wait.
You wait. That's the number one sign that edema is subsiding, is weighing the patient. And also you should see what? A decrease in shortness of breath.
Mm-hmm.
Yeah. And how do you evaluate if someone is having a decrease in shortness of breath? What would you see? What does that look like?
They're using their
Oxygenation.
their diaphragm to breathe.
Yep.
Less use of the accessory muscles.
Yep. Pulse ox is normal. And they may tell you, I feel better, I'm breathing better, I don't feel short of breath. And they may be able to ambulate without holding a wall or without huffing and puffing. So this is what we're doing in level 2. Treating, assessing. All right. We're going to move on to Ronchi. So who wants to tell me about Ronchi? What disease process may you see this with?
Is it bronchitis?
Bronchitis.
COPD.
Okay. And they say Ronchi is actually a snorer's wheeze. And how do you know if a patient have Ronchi versus a wheeze?
You can have them cough, and if it goes away.
Exactly. It may be clear of a coughing or a suction, and that's how you could differentiate Ronchi from wheezing, but it is a snorer's wheeze.
The Ronchi you could clear with a cough.
Yes.
Okay.
You can clear it with a cough. Ask the patient to cough, listen again, and it's Ronchi. And they may or may not have shortness of breath with a Ronchi. Just assess your patients. And so now we have wheezing. Sometimes wheezing is so loud, you can hear it at the door. And you'll see this a lot with what disease process?
Asthma.
Asthma.
Asthma a lot. Yep. High pitched whistling sound. And so it's typically heard during expiration. And so if you hear it with expiration and inspiration, that means that the narrowing has progressed and the bronchospasms are getting worse. So you need to prepare to, this could become a medical emergency. I'll just say that. When I worked, so I'll tell everybody, I don't know, I didn't tell all you guys, but I'm an emergency department nurse by trade. That's where I worked. So when we had patients come in with complaints of asthma, they didn't wait. We brought them immediately to a bag, immediately to a chair or a bed, and we started breathing treatments because things like this can happen. You can have wheezing during expiration and inspiration, which is worse. So when you're assessing patients with wheezing, the things you want to look for asthma, the things you want to look for is, are they using their accessory muscles? Here we go again. It's not going away. Are they using accessory muscles? And if so, which ones? Can they speak in clear sentences? Are they just like no? So we know they're having a hard time breathing, right? And another good question to ask when you're dealing with a patient with asthma, and you're going to learn this again, is have they ever been intubated? Because if they've been intubated once for asthma, the likelihood of the chances of them being intubated again is high. So we want to ask all of those questions. So we treat wheezing with, depends on the cause. So we have to determine the cause. So yes, asthma is one of the main causes, but there's other things that may cause wheezing. So we need to determine the cause of the wheeze and then treat the cause and assess from there. And our last, no, except the last. So then we have pleural friction rub. So anybody want to tell me about pleural friction rub?
Is that like with pleurisy?
And what's pleurisy?
It's like the two, they stick together, the walls.
And they'll have pain. Yep. And also pneumonia. So again, if you have a pleural friction rub, you need to find out what the cause is. It could be pleural, it could be pneumonia, and treat the cause and reassess. And this is typically heard during inspiration and expiration. All right. And sometimes this is confused with a pericardial friction rub. And so, way to determine what it is, you ask the patient to hold their breath. And if you don't hear it, then it's probably cardiac. And stridor. Has anyone ever heard stridor? You're going to hear it in a second. But this can be a medical emergency because it is a partial obstruction of the larynx or trachea, which is your upper airway. And so you can have obstruction of the airway because you'll go into respiratory distress. And yeah, we don't want that to happen. And you'll see it a lot in kids because their airways are small. Kids can choke. That's why they don't want them eating hot dogs. They don't want them eating grapes because it can get lodged in their throat and obstruct their airway. And you hear this with inspiration. And also could be caused by croup, epiglottis, or vocal cord edema after extubation. So when do you think you would see this, the vocal cord edema? So the patient goes to surgery and they come back, you need to be sure that you are assessing them once they get extubated, right? Because we want to avoid respiratory distress or respiratory failure. But this could absolutely be a medical emergency. And this is loudest over the interior of the neck. And lastly, we're going to discuss absent breath sounds or diminished breath sounds. So breath sounds could be diminished for a number of reasons. And why do you think they may be diminished? And that's just a decrease in the distant vesicular lung sound. They're decreased. So they're not gone.
Because of fluid in the lungs, because of more.
So a lot of times it's caused by poor respiratory effort. So you'll have patients, maybe they have rib fractures and they just not taking deep breaths. So you don't hear any crackles or adventitious breath sounds, but you hear very faint breath sounds because they're not taking good efforts. And you'll ask them, can you breathe a little deeper for me? And they just don't. For any number, maybe they're tired, maybe they just had a surgery, maybe they're splitting. So you'll get this. And sometimes you'll see it in emphysema. So it's called poor respiratory effort can cause diminished breath sounds. You don't hear any adventitious sounds, but you hear the sounds very lightly. And it can be very normal. And you can try to get the patient to breathe. And if they need something for pain, then maybe we need to get them something for pain and go back and reevaluate. So absent breath sounds, that's never good. So, but you could have absent breath sounds in certain lung fields, and they could be caused by pneumonia, heart failure, and pleural effusion. Again, you need to find out what's causing it, get to the cause, and treat and assess. So what are some diagnostic tests you may see with respiratory issues?
Pulmonary function test.
Pulmonary function test, chest x-rays. You might see people using a peak flow.
Pulse ox?
Pulse ox, definitely, incentive spirometers. So there's a number of things that you'll see used, and of course, respiratory therapy would be collaborated with these patients. So let's talk about cues and subjective data. And subjective cues, of course, is what the patient tell you. And so, what can the patient tell you? What would they present with if a patient has a respiratory issue? What might be some of their complaints? There they are.
I can't breathe, short of breath.
They are.
Pain.
Pain.
They're having pain. They can't breathe. They may have fever. They may be coughing. They could be productive or non-productive. They may have rib pain, and that pain could be just from coughing so much. And you need to ascertain that. If someone with a respiratory complaint come in and they say, and I have chest pain as well, so you want to kind of assess that chest pain further. You want to find out, do you have chest pain only when you take deep breaths? Do you have chest pain only when you cough? And it may just be rib pain from excessive coughing, or do you have chest pain at rest? That maybe they have a cardiac issue going on. So you have to evaluate that. You want to know when all these symptoms started. So these are things that the patient can tell you. They can tell you if they're sleeping on 3 pillows. They can tell you if they having a dyspnea on exertion. Whenever they move or try to do something, they may be short of breath. So those are things that they can tell you.
What about fatigue?
They can, they can. That's what I'm saying. They can tell you if they've been tired lately. Anything else?
Feeling faint.
So they can, if they're hyperventilating, then they will get that faint feeling. So, and sometimes
anxiety.
And that's what I was about to say. Sometimes you'll get shortness of breath with anxiety, a tachypnea with anxiety. So, all right. So we already said it's best to have the patient sitting to examine the anterior and posterior. So we're going to start with inspection. What are we inspecting? It's all right there. So what are you, when you're inspecting the nose, you're inspecting it for patency, what could be an issue? Maybe they have like some swelling in the nose. Maybe they have a nodule or not a tumor, or something in there that's kind of blocking the airway. And when you're looking at the mouth and the larynx, what are you looking for?
Swelling.
Inflammation.
Inflammation.
Swelling of the tonsils, the tongue, and you'll see tongue swelling when patients have angioedema. They'll take your Pril drugs, and a lot of people have allergic reaction to it, and that's one of the reactions. They'll have that tongue swelling. And what do you think you do for that? If a patient comes in with a large tongue, what's the danger in that, and what do you think you do?
Should be anaphylaxis.
Anti-inflammatories.
Benadryl, steroids.
Of obstruction.
So yeah, you would assess your patient, because every patient is different. I work the ERs, patients come in, they have this angioedema, and they're talking, and they look good, and their vital signs are stable, and they're maintaining their airway. We'll give them, some antihistamines and things to try to get that swelling down. But we're going to assess. We want to assess to make sure it doesn't get worse, right? To make sure they don't start drooling, to make sure that they continue to maintain their airway. And these are patients that will probably get admitted overnight, and we have to continue to do their respiratory assessment. Someone needs to, thank you. So you want to make sure you don't have swelling in the tonsils. And you want to check your neck for symmetry. Sometimes you'll have swelling if you have like a large abscess that could occlude your airway. So you're assessing for anything that has the possibility to a propensity to occlude the airway. And when you're checking your thorax, what are we inspecting for?
Making sure they don't have a barrel chest.
Yeah.
Accessory like emphysema.
And making sure both sides are moving at the same time, they're expanding at the same time, and one's not lagging behind, like you don't have flail chest or anything like that. So we're assessing that as well. And skin color. What might you see in skin color? What are you assessing for with the skin color?
Make sure it's not blue or gray.
Color.
Cyanosis.
Cyanosis.
So she said making sure it's not blue or gray. So like who would have gray skin? Where would you see like the gray skin color and what persons?
African American.
Black.
Dark skinned persons. It could be Indian.
Oh yeah.
Dark skinned persons, yeah. You may see you have poor perfusion, you may see the grayish color. But how will their mucous membranes be and how will their cap refill? It'll still be pink.
Miss Cal,
Yeah.
I never saw the gray skin. I saw the bluish. I saw the blue, the cyan, but I never saw gray before.
Keep looking. I never saw it either, but keep looking. You may see it. And now you'll start looking for it and you'll be like, oh, okay, that's what that is.
I saw it on a white guy once.
Really?
He drowned.
Oh. So, yeah, so that's what we're inspecting for. So it really should be auscultation and then palpation. So palpation, what are we palpating for?
Symmetry, inequality, and pain.
And making sure your trachea is midline. So if you have a shift in the trachea, what could be causing a tracheal shift?
A tumor.
A tumor?
Collapsed lung.
Collapsed lungs. Yep, they can cause trachea shifting. So yes, we'll do inspection and auscultation. So we talked a lot about auscultation already. 1 cycle per site. Do you want an inhalation and an exhalation every time you move that stethoscope? And so you know the normal adult respirations, and it's not 16. And you know some nurses put 16 for everybody, but make sure you're counting those respirations because in some instances you're checking for. I've been out of work too long. Not shocked. I can't remember. Sepsis. So when you're assessing for sepsis, is based on like your heart rate, your respiratory rate, your temperature. So when you fudge in rates, you may be, predisposing someone to sepsis or delayed treatment of sepsis because we're fudging respiratory rates. So we need to make sure that we're counting these rates because we want to treat people properly because if they have 2 abnormals in that respiratory, temperature, and heart rate, then we need to start sepsis workup, the initial sepsis workup. So make sure that we're getting accurate respirations. And when you are a student and you're working, and you're doing vital signs and you're counting, if they're abnormal, tell somebody. You can't just hold this information and not say something. If the nurse not interested in the information that you're providing her, that's A-okay. But if you're counting and you get 34, let the nurse know. And it may be normal or baseline for that patient. It may be. But if you don't know, you make sure you give that information and close loops, right? We want to close loops. We want to find out something abnormal and keep it to ourselves. All right. So this is the auscultation. I think y'all talked about these landmarks starting at the 2nd intercostal to the 6th rib. So this is along with your landmarks. So make sure you know your landmarks. And we can't forget our gerontological patients and their considerations because the population is getting older because of all this good medicine and all this good nursing care. Population is getting older. So things are going to be different in the assessment of an elderly patient as opposed to a middle-aged person. So you just kind of need to know that their respiratory rate will be more increased because they're working a little harder to breathe because their skeletal muscle strength is just not the same. So kind of read through your gerontological considerations. You can't forget about our elderly. So let me just give you a little scenario. You're getting reports, you go into a room, your patient is lying down kind of flat on a pillow, and he tells you he's having some difficulty breathing. What is the first thing you as a nurse need to do?
Elevate the head of the bed. Elevate the head of the bed.
Elevate the head of the bed. We need to treat the person. Elevate the head of that bed and start your assessment. Get your pulse ox. We might need to put them on oxygen. See if they need to be suctioned. You need to do all of that before you do what? Call the doctor. Take care of that patient. Very good. Can't trick y'all.
Miss Cloud, I had a nurse who triaged a patient, and she said that his pulse ox was 100%. She said that his respiratory was 18, and when I'm getting him the man, difficult breathing, put him on a pulse ox, everything. And I'm like, I know you lying.
So tell me this, was this a novice nurse or was this an experienced nurse?
Experienced nurse. I think she burnt out and she just...
So I don't like to speak on, because maybe that patient was normal when she saw the patient, and maybe he sat in the waiting room for 3 and 4 and 5 and 6 and 7 hours. And when he came to the back and got a room, maybe the assessment changed. I don't know what the circumstance was. Because I hope she didn't get out the triage chair, go straight to a bed, and that's what they look like. Because that happens. I worked that chair at the ER, and we triage a patient, and I come back the next morning and that patient's still sitting there. So his whole assessment could have changed so I don't know. Any questions about gerontological considerations?
I was curious if surfactant would decrease as people age.
Will it decrease?
Yeah.
Find out and put it in a discussion post.
All right, I'll do that.
Everything decreases. So you're going to hear me say a lot in that in clinical. If I don't know, you're going to find out and you're going to present it to the whole group. Any question about respiratory assessments?
Will we be able to get listen to the sounds?
Oh, yay! Thank you.
Adventitious breath sounds. Stridor. Stridor is a continuous, high-pitched, crowing sound heard predominantly on inspiration. The cause of the sound is generally the partial obstruction of the larynx or trachea. Stridor may be heard in conditions such as croup and foreign body obstruction. It's typically loudest over the anterior neck as air moves turbulently over a partially obstructed upper airway. Wheeze. The sound of a wheeze is a high-pitched, continuous musical sound. This is caused by air passing through an obstructed, narrow airway. The classic wheeze may be referred to as a sibilant wheeze. This refers to the high-pitched whistle-like sound. Alternatively, what we often refer to as rhonchi is the sonorous wheeze, which refers to a deep, low-pitched rumbling or coarse sound as air moves through tracheal bronchial passages in the presence of mucus or respiratory secretions. It is commonly heard in the lungs during expiration. It may be heard in asthma, emphysema, and chronic bronchitis. Crackles. Crackles are also known as alveolar rales. The sound crackles create a fine, short, high-pitched, intermittent crackling sounds. The cause of crackles can be from air passing through fluid, pus, or mucus. It is commonly heard in the basis of the lung lobes during inspiration. Crackles can be further categorized as coarse or fine. Coarse crackle sound quality is low-pitched and moist. It may be heard in pulmonary edema and bronchitis. High crackle sound quality is like hair rubbing near the ear and may be heard in congestive heart failure and pulmonary fibrosis. Rub. The pleural rub sound results from the movement of inflamed pleural surfaces against one another during chest wall movement. The sound quality is considered a harsh grating or creaking. Potential causes include tuberculosis and pneumonia. It is best heard in the lower anterior lungs and lateral chest during both inspiration and expiration. To learn more, subscribe and visit osmed.com.au.
So can I ask, is that all you're going to hear? Like, you're not going to hear other breath sounds over that, right?
That's probably all you're going to hear.
Okay.
Yeah.
Okay.
But again, every assessment is different. But when you hear wheezing, that's mainly what you hear is wheezing. And you have to think about, what are you hearing wheezing? Is it bronchitis? Is it, so what condition does the patient have? And that'll cue you into what sounds you'll probably hear. So if a patient has CHF, you'll probably be hearing crackles. If a patient has asthma or bronchitis, you'll probably be hearing wheezing. So you just have to, the more you do, the more you'll get accustomed to hearing it. And if you don't hear it, if it sounds like it's not normal, then get someone else to come here with you, right? So that's never a problem. Say, I think I hear crackles, but I'm not sure. Ask your instructor, ask another student, ask the nurse. Even when you're a nurse, I still ask people because I buy cheap stethoscopes and I don't know. So I'll borrow another stethoscope. Ask someone else to come listen with me just to confirm or verify. And when you're doing a history taking on these patients, what other questions might you ask them?
Do they have a history of smoking?
Do they have a history of smoking?
What environments they work in?
Oh, good one. What environments?
Have they experienced this before?
Oh, that's a great question. I always ask patients that. Have you had this before? And if you have, how did they treat it? And how did that treatment work for you? That's a great question to ask. One of my favorite questions. And if they're coughing, is it productive? Is it non-productive? What are they coughing up?
You color up this button.
How long does it last?
How long does it last? When did it start? Very good. So yeah, just like Ms. Pat said, so we can't go over everything, but we try to pick out the important points, but make sure that you read in your chapter because there's way more assessment data that you could ask the question, way more questions. So make sure that you go review it. So we are going to take a break here. I think that was it. And when we come back, we'll talk about the cardiovascular system. Any questions? If you think of something later, just put it in a discussion board. We want you to use that board. So someone else may have the same exact question. So I'll see you guys back in 10 minutes.
Recording stopped.
Hey, girl, you're doing great. That is very nice. When did you start? According to the calendar, it's supposed to be 9:45, right?
Huh?
Carol said that.
Dr. Ewing, you need to mute yourself.
Recording in progress.
Hello. Having technical difficulties. I'm coming, guys. All right. Is everyone back?
Yes, ma'am.
I'm sorry, I had to run to my car. I was using a hotspot from my phone and my phone was dying. Then I couldn't get back in. Then I don't have the right charger, but we're good now. So we are moving on to the cardiovascular system. And so we start with the function. It's to deliver oxygen, nutrients, hormones, and other substances to the cells and organs, and it plays an important role in helping the body meet demands of exercise, activity, and stress. So that is the function. And I have a little heart with the blood flow through the heart. You can see your ventricles, valves. All right, so let's talk about auscultations and landmarks. Someone kind of run through this with us. This is where you going to listen for your heart sounds. at these different points. Where do you start? Like, how do you prepare a patient for a cardiac assessment? Let's start there.
Hand hygiene, privacy, patient ID.
Ask permission.
Yeah, explain.
Explain. Tell them what you're going to do. Tell them that you're going to have them move several different positions. Yep. And where should we place the stethoscope? Should we put it on top of their clothing?
No.
Nah.
We should make sure they're in a gown so we can have the stethoscope to their chest. So you want to warm the stethoscope, right?
Yes.
Rub it in your hands. And when you're using a stethoscope, when you're going from patient to patient to patient, what should we be doing in between each patient?
Cleaning the equipment.
Cleaning that, sanitizing that stethoscope. And use standard precautions provide for privacy. You got the same landmarks that you use for the respiratory assessment, right? So you need to know where all of these heart sounds are located. I could just tell you that now. You need to know where they're located. In the mitral area, what heart sound is that?
PMI.
PMI.
Wait, what?
You're listening to the apex of the heart was the mitral area, right? Fifth intercostal space, mid-clavicular line. So make sure you know your auscultation marks. And there's a nice little picture that kind of goes through the auscultation landmarks with you. So once you assess, you prepared your patient, and now we're gonna, so these are your normal heart sounds, and these are extra heart sounds. They tell you what they sound like, and I don't have the sounds for the heart sounds. I'm sorry. So you guys could just kind of Google it. That's what I did. I went to YouTube and I just Googled it. But they talked about your S1, your S2. Those are your normal heart sounds. And sometimes you'll hear a ventricular gallop or atrial gallop. And all you do when you hear those sounds, make sure that it's documented, or if someone already knows about it. If you don't know what you're hearing, again, you can ask someone else to use it. To listen with you, auscultate with you. And also, if you work at a teaching hospital, you just grab a resident. They do not mind. Because just like you guys are assessing and practicing so you can get better and better and better, they're doing the same exact thing. So grab somebody. If you think like, I hear the S1 and S2, but I hear another sound, grab somebody. And there's not much from a nursing aspect that you'll do about it, unless they want an EKG. I don't even know if it's seen on the EKG. You'll go over perfusion with a great instructor. Ms. Hanhart is going to get y'all together, but we'll start off. So you know your landmarks and we know what we're listening for. And then you may hear murmurs. They could be structural defects in the valve. Again, if you think you hear something, but you're not sure, grab somebody and ask somebody, what do we do about murmurs? Not a whole lot. You'll hear patients come in and they'll be like, I have a history of a heart murmur. No treatment, no medicine. Unless it gets too bad, then he might treat it or, do a procedure, but usually nothing. But know that they're there and know that you may hear them in addition to your S1, S2 heart sounds. So now we're going to discuss some abnormal heart sounds. And there's a pericardial friction rub. So who can tell me about that? It's all there. Like, what did you read in addition to the things that I have here? So it's heard with inflammation of the pericardial layer. You may have tachycardia, and it's louder during inspiration. And it's a high-pitched grating sound. And this is the one that's confused with the, which one was it?
The pleural rub.
Yes. And if you hold your breath, you don't hear it, it's probably pericardial. Thank you. I know if we talked about blood pressures, so we blew in the face. Oh, I spelled something wrong. So what are we doing for blood pressures? How do we prepare the patient for blood pressures? Where do we take it? How do they need to be positioned? So we want to make sure that we know how to do things right. So when something is wrong, we could be, sure that it is wrong or elevated or abnormal rather.
In a sitting position, feet flat on the floor, no talking, arm at heart level. Yeah.
Make sure the cuff is the right size.
Make sure the cuff is the right size. Yep. So if I'll just bring this up, I'm quite sure your instructors. So if you're doing a vital and you have an abnormal or elevated or a low blood pressure reading, what do we do with that?
Retake it.
Retake it. You could do that. And if it's still elevated or still low, what do we do?
Take it on the other.
They're normals. It might be normal for them to have a high or a low.
Exactly. It may be normal for them. So we need to see what their baseline is. And also we need to tell someone. So we're not dropping balls. So you've taken vital signs and you get something that's really elevated, we have to let somebody know. And this talks about your pulse pressure. You can read through that at your leisure. All right, let's move this. Some cues, some subjective cues. What can the patient with a cardiac issue tell you? What might they present with? What would this patient look like?
Chest pain. They would have chest pain. It could be sweating,
Stomach pain, arm pain, back pain.
Fatigue. Flushing.
This patient may have a plethora of complaints because they also have respiratory complaints. So it's our job as a nurse to, whatever complaint, so they tell us pain, we need to investigate the pain. And how did you learn to investigate chest pain? What questions are we asking?
What's the rating?
Scale, or 1 to 10 or whatever.
If it's stable or unstable.
Does it go away with exertion or start with exertion? Does it radiate?
You want to know when it started, does it radiate, what makes it worse, what makes it better? What does it feel like? Is it a aching, a dull, or throbbing? So you want to ask all those questions. You want to ask if they do any heavy lifting. So we want to make sure, try to see if it even is cardiac related. Maybe they lifted a big sofa and then it's just, they'll call it chest pain, but in actuality, it might be costochondritis. So we need to evaluate that chest pain further. And we know that sometimes women have different complaints when they have MIs or heart attacks. They may complain of the shoulder, the arm, the jaw, the abdominal pain, right? Mm-hmm. So what tests are we getting? Someone comes, are you working the floor? Are you working med surg? And they say they're having chest pain. And if they have the history, they have hypertension, they've had chest pain before. We've already ascertained that they had stents, or you may be on a cardiac care unit. What are we doing? What's one of the first things we need to do? First diagnostic test we need to get?
EKG.
Blood work? EKG. We need to get an EKG. We'll get blood work too, but if someone says they have chest pain, we need to get an EKG because there's something called core measures, and MIs is on a core measure. EKGs need to be obtained within 10 minutes because if they need to go to the cath lab, they need to get to the cath lab in a certain amount of time. So yes, get your EKG. And they also may have tenderness in their calf, legs, right? Anything that could mess with their perfusion. And we talked about the color. Poor perfusion produces a gray color in dark-skinned people, and lighter or fair-skinned people present as blue. And also, when you talking to these patients, you want to pay attention to their breathing pattern, because with congestive heart failure, they may be, using some accessory muscles. They may be tripoding, and also if they're coughing in their skin. And these patients also may tell you that they've been feeling faint lately or dizzy. And that's what you call syncope. All right. And it's just talking about getting more subjective data that you could obtain from their health history. So you want to know if they have a cardiac history, because sometimes you won't think that a 45-year-old man will be having a heart attack, but once you get that family history, he may tell you, my dad had a heart attack at 45. So then we're on alert now. So you want to get the family history. And that's another question we ask, you know, do you have a family history? Or did anybody in your family have a heart attack at 45 years old? And say, yeah, okay, well, we need to move on that. So you want to ask them about all their medication that they're taking. And also you can use the what illicit drug may cause chest pain. You need to ask them about drug use.
You said it caused chest pain?
Yeah.
Is it cocaine?
Cocaine. All right. So you want to ask them about drug use. Ask them about any allergies, because if they have to go for cardiac catheterization, we need to know if they're allergic to iodine. Evaluate those risk factors, and then if they smoke, that we have a little how to determine how many packs per year. And we always want to, speaking of smoking, we always want to encourage them to stop smoking, right? We want to always, because it causes what? Vasodilation. And it causes respiratory issues. So you always have to try to encourage a patient to stop smoking.
It's Cloud.
Yes.
What did you say about the iodine? Why we need to know if they're allergic to iodine? I didn't hear that part.
In case they have to go for a procedure, a cardiac catheterization, if they need to go for a CAT scan with contrast, we need to know if they're allergic to iodine.
Okay, thank you.
We don't want to cause more issue.
Ms. Cloud, if they are allergic to iodine, what would be used as an alternative?
I'm not even sure at this moment. Maybe they have to get a different, I'm not sure. Put that in a discussion.
Can you go back real quick?
Yes. So what?
The previous slide.
Right here. And all of this is in your book. It's just how you obtain the patient's health history. And this is what you're going to obtain on every patient.
Thank you.
Of course. So how do we obtain objective data? What objective data can we obtain from these patients with cardiac complaints?
Vital signs.
Pulse ox.
Yeah, vital signs, pulse ox. We want to get their weight again. If
labs,
especially if they have CHF.
Your observation, anything you observe.
Anything you observe, and we're going to get to that. And so, you ever heard of the doctor wants some orthostatic vitals? Everyone hates to do orthostatic vitals. Oh, and going back to the iodine, if they're allergic to iodine, we could do tests without iodine. You just get a better picture when you use the iodine because it kind of lights up. So you still could visualize abnormalities without it. Back to the iodine question, of course.
Thank you.
No problem. Who's done orthostatic blood pressures? And can you delegate this to someone? Can you delegate the orthostatics?
Yes.
No. Because it's abnormal.
you can, but they can't like assess the findings.
Exactly. I'm about to say, because we've done it all the time in the ER. This is something everyone hates to do, but what does this indicate? A positive orthostatic orthostatics.
Orthostatic hypotension. Orthostatic hypotension.
Yeah, what is it indicative of?
Probably from medication or
Really low blood pressure.
Hypovolemia, dehydration.
Side effects of medication, like antihypertensives and things like that.
Yeah, so if a patient come in and say they feel faint or dizzy, they're probably going to get some orthostatic vital signs. And it kind of tells you like is results from peripheral vasodilation, and the blood leaves your central body organs and moves to the periphery. And that's why they feel faint and dizzy. And it could be because they're in shock and they're losing a lot of blood. They could be hypovolemia because they're vomiting or having diarrhea and they're losing a lot of fluids, right? So what do you think the doctor would do to treat a positive orthostatic vital signs? And how do you take them?
Well, you take them by first having them go from lying, slowly take their blood pressure, slowly have them move to the sitting position, take their blood pressure, and slowly carefully move them to a standing position, take their blood pressure.
And which two vitals are you assessing, and what kind of changes will kind of cue you into it's positive?
Heart rate and blood pressure. Blood pressure will drop, heart rate will rise. It's accommodating for the drop in pressure.
Very good. And if they say they're dizzy, so all of those are positive signs, and you let the doctor know, and you can anticipate what kind of order.
Fluids.
You can anticipate that patient, and what kind of fluids will they get?
Hypertonic.
Isotonic, probably normal saline. So they'll probably get isotonic fluids if they are positive.
Also, Ms. Cloud, they can anticipate that for an order for the patient to be up with assist only, to eliminate falls, or maybe, bedside commode or what have you, or not getting out of bed at all, depending on the assessment between those gradients of blood pressure, lying down, sitting, and standing. Because if they're sitting up and they pale out and they start sweating and they're getting dizzy, you're not going to have them stand up to get another blood pressure, because what are they going to do?
That's true. Fall.
Yes, fall.
Pass right out. So you're going to have them lay back down and everything, and then report, the blood pressure of those two, and then, follow up with the subsequent orders.
Thank you, Ms. Lee. Thank you. That's true. And I see that a lot of people are just doing lying and sitting just as a standard. I don't know if that's the standard, but I see that happening a lot. They'll just do lying and sitting.
Well, because they're symptomatic. If you have them stand up, they're already symptomatic with getting dizzy from sitting and just being in that upright position. Standing could actually cause them to faint. And so when they're symptomatic, you just lay them back down and you put what you see, what the blood pressure was, and that, it was not safe to stand them up. And it could also mean that they have some kind of venous insufficiency in their valves when they've been on bed rest for an extremely long time, even though they may have plexi pulses or TED hose or whatever on to help with venous return. Sometimes what keeps gravity from drawing the drawing all our blood down to our feet is what? From A&P. Remember, we had those receptors. Valves and the receptors that cause some vasoconstriction that keeps our blood where it needs to be within our body. And if those are insufficient, then the blood can drain from the head, and that's what causes the dizziness and stuff is the lack of perfusion. So you need to get them in a more recumbent position to allow blood flow back to the brain.
Thank you,
Sorry, Miss Cloud.
No, I appreciate that because I forget things. I haven't worked in a while, but yes, everything she just said is absolutely true. If they're unstable, if they can't stand, do the line of sitting and make sure you're reporting it off and provide for their safety. Thank you, Ms. Leaf. So any questions about orthostatic or postural BPs? She gave a great explanation for me. All right. So inspection. What are we inspecting for? What might we see?
Edema, sweating, or diaphoresis.
So what about the edema? What kind of edema would you see? Like how would you describe the edema? Like if you had to write a narrative, I know we don't write anymore, everything is electronic, but if you had to write a narrative to describe the edema, what are we saying? What are we looking for in what edema?
Pitting edema. 1, 2.
What is pitting edema?
And I think 4.
Whether it's pitting or not, how far up it goes. Yeah.
Generalized.
If it's dependent, because some days you're just walking around and you may go home and you may have swelling, but there's no pitting. So yes, you want to make sure that you're very specific about your documentation of your edema.
Good point.
Yeah. What else are we looking for? Skin color. We talked about the skin color.
And would the temperature indicate an issue as well?
Yeah.
Blood getting there, we cold.
Yep. That's a perfusion issue if you're cold. Yep. Or if you have pallor. Hair distribution. What would be the issue with the hair distribution?
Lack of hair from poor perfusion.
Lack of hair. Yep. And so you also looking for distension, jugular vein distension. So who knows how to assess for jugular vein distension? Where are we looking?
You push on the liver and you look at the jugular, and when you press on the liver, if you have jugular vein distension, you'll be able to see the jugular vein kind of rise as you press.
And sometimes it's just prominent. You could just
sometimes it's just out.
Yep. Sometimes you'll just see it. And that could be a sign of heart failure. And you'll learn more about heart failure with perfusion.
And there's ways to do all.
I can't hear you. Is someone trying to say something? All right, so auscultation. So we already saw our landmarks. So we're making sure that we auscultate our landmarks, and we want to listen to the patient in a seated position, and then we want them to lie on their left side. What do you listen to when you lie the patient on the left side? What sound are you listening for?
The heart. The output from the ventricle?
Your apical pulse?
The apical pulse. It's the best way to hear it, all right? So they say first you're going to auscultate with the diaphragm for your high-pitched sounds, and then auscultate with the bell for your lower-pitched sounds. And when you're listening for a bruit, that is probably heard over the carotid, and you'll hear that if you have some narrowing to the artery. And document your findings and make sure that you relay them to the appropriate providers. Any questions about the cardiovascular assessment, questions that we'll ask in treatments for these patients?
Can you say again what the bruit indicates?
just narrowing of the artery, and you'll most likely hear it over the carotid. And when you are palpating the carotid arteries, should you palpate them at the same time?
No.
No.
And how do we assess the cap refill?
You press down on the fat.
Your nail beds,
RPG.
your nail beds, the tip of your finger,
Or you can do the toe, right?
Right.
or the top. Mm-hmm.
And she come back to color within 3 to 5 seconds.
Yeah. And if it's sluggish, it may indicate what?
Perfusion.
Arterial insufficiency.
What is it?
Arterial insufficiency or arterial spasm. So yes, it should be less than 3 seconds.
Ms. Cloud, I have a question.
3 to 5 seconds, right?
I'm sorry?
Less than 3 seconds, not 3 to 5 seconds, right?
So it's less than 3 seconds. Who had a question? Was that Amir?
Yep. Yes. No, Ryan, I have a question.
Ryan,
So
sorry.
what is, oh no, that's okay. What is, so if you see clubbing of the nails, what is that like indicative of?
Poor perfusion or chronic hypoxemia. Like you'll see that a lot of people that smokes.
Don't you also see it in like sickle cell anemia?
I have not.
Well, they do have oxygenation problems a lot, but I don't know.
All right, thank you.
And have perfusion problems. I just haven't seen it or paid attention.
And I'm sorry, one more question. If it's multiple nails that's clubbed, or does it have to be multiple nails that's clubbed, or just one?
When I've seen it in a patient that smokes, it was like all of his fingers were clubbed.
Absolutely. This is Carol Leaf. That's all of the nails will be clubbed. Okay. And it kind of looks like a spoon. You can see pictures of it if you Google it and stuff. And that comes from years chronic hypoxemia. Okay. Chronic hypoxemia. It will not just show up in an acute respiratory condition.
All right, thank you so much.
Yes. Is that it? All right, so again, we have to think about our gerontological considerations and just know that there'll be changes. The heart is older, it's not working as great as it used to work, and hypertension is not considered a normal sign of aging. Hypertension is not normal in any age, right? And your valves are thicker, so you may have more cardiac dysrhythmias in the elderly. Anything else that I'm missing? Any questions about the cardiovascular assessments?
I have a question, Ms. Cloud. If somebody has a pacemaker, when we auscultate, is it going to sound different than, like a normal cardiac assessment?
So I would say no, and you shouldn't really be assessing like over the pacemaker. You'll assess, in your regular landmarks, but no, it shouldn't sound different. Your EKG may look different, but I'm not authority on cardiovascular. Is Ms. Hanhart on here?
Yeah, I'm on. You won't hear anything, but you will see pacer spikes if it's being paced. Most of them have settings like high or low of when it would kick on. So it's only if it's actually being paced, you'll see the spikes on the telemetry or the EKG strip.
Yeah.
Okay, thank you. I was just curious.
You won't hear anything, but you'll see it on the EKG. Thank you, Ms. Hanhart.
You're welcome. And the only time you'll hear something is if someone had like a prosthetic valve that is metal, and you don't really hear those too much anymore because they usually now use more pig valves and synthetic valves.
Thank you. All right. Any questions before we move on?
You said that the pericardial friction rub can be confused with something else. I forgot what the something else was.
Floral rub.
The pleural friction rub. Thank you.
Thanks a lot.
All right. Now we're going to move on to the neurovascular assessments, and it has 3 components: the circulation, motor function, and sensation. And this system is dealing with the adequacy of perfusion to your extremities. So what kind of signs and symptoms do you think you'll get when you have insufficient perfusion to your extremities?
Pain. Color of the skin, numbness, cold.
The temperature of the skin.
Yep. So that's why you're going to assess your P's with your neurovascular assessments. You're going to, the subjective P's, the P's that the patient can tell you about is pain, because we, you know, they have to tell you this. We don't know if patients are in pain. And pain is whatever they say it is, correct? And paresthesias. And people confuse numbness with tingling. And so you have to like really question them. So numbness meaning you can't feel anything, or do you feel tingling? And that's your paresthesias, is the tingling. All right. And these are the other P's: your pallor, your temperature, your pulses you guys mentioned. We talked about perfusion, paralysis, puffiness. And where might you, and under what circumstance may you have to assess this?
Blood clot?
Your extremities.
Yeah, blood clots, maybe peripheral vascular disease. And also if someone has a cast on, right?
Yeah, compartment syndrome could be an issue.
And so what needs to happen if any of this occurs? Pain is incongruent with the injury. And
remove the obstruction?
Yeah, you have to remove it. The cast got to come off. So we need to call a doctor about getting a cast off. And so before the patient goes home, you need to tell him what to look for. And you may also have neurovascular issues with diabetes, right? That's why people get amputated, because the perfusion is so poor to the periphery. They lose their pulses. So, and speaking of assessing pulses, if you're assessing dorsalis pedis pulse and you don't feel it, what should you do?
Go up to the next one.
Go up to your tibial.
Use a Doppler.
Use a Doppler.
Use a Doppler, because if you don't feel that one, you probably won't feel the other ones.
So I don't know. So if I was assessing a pulse, a dorsalis pedis pulse, and I didn't feel it, and a patient doesn't have any other symptoms, they have good perfusion, good color, they're able to move their feet, I would get somebody else to feel it, because they have to have a reason to pretty much not have a pulse down there. So get someone else to feel it. Maybe it's just you. So I would get someone else to feel it. If everything else is normal, they should have a pulse. And yes, you move to the closest pulse to the one that you can't feel. But 9 times out of 10, if they don't have a reason not to have a pulse and everything else is normal, they probably have a pulse there. You just can't feel it. And if someone else comes to look, then of course get a Doppler. But if the patient can move their toes, color's good, we need to feel the next pulse up.
I'm sorry, to be clear, you said that if you have a reason to get a Doppler, and if you don't, to just get someone else?
So if you're going in to assess the patient and you can't palpate the pulse, so you look at the other symptoms that you look at other things that may suggest that they have poor perfusion. So you look at the color, the temperature, the cap refill, and can they move it? So all of those things would tell me that this patient is probably perfusing. I just can't feel the pulse. I would get someone else to come and see if they can feel it, because 9 times out of 10, they probably have one, or you check the next pulse up, right? The nearest pulse to them. And if you still can't feel it and it makes you comfortable, then yes, get a Doppler.
Thank you.
And if they do have some type of reason, maybe they have diabetes and maybe they already have circulatory issues and you can't feel a pulse and they had one when he came, then yes, I definitely would get a Doppler. If the patient came in with like maybe a 1+ pulse, but it was there. And now today you're doing the evaluation and now we don't feel a pulse. That's definitely a good reason to get a Doppler, because his skin is probably dark, right, from poor perfusion. So every patient is going to be is going to be different. And if you can't feel a radial pulse, what's the next pulse you'll check?
Brachial.
Brachial. And again, you're going to do the same thing. I can't feel a radial pulse, but the patient has good color. The patient has good movement. The patient has good capillary refill. And the patient just doesn't have a reason to have decreased perfusion to the extremity. So get someone else to feel for you and go to the next pulse, the nearest pulse.
If you do hear it with the Doppler after all that, you just chart it as normal.
You chart it as that you needed a Doppler to hear. You need to chart that you needed a Doppler to hear it.
Okay, thanks.
Sorry, go ahead.
Yeah, you will see it marked. Sometimes people write X's just to let you know that's where we heard it, with a Doppler or palpating.
So I'm sorry, I need to clarify. You only use a Doppler if the pulse is weaker than before, or if they're symptomatic, or like if you can see that they have poor perfusion. Like you don't use it just to find a weak pulse, just if they're asymptomatic.
Even if they're symptomatic and you want to make sure that they have a pulse, get the Doppler. It's not wrong to use a Doppler when everything else is normal. If you don't feel it, and if your coworker doesn't feel it, and if y'all feel more comfortable getting a Doppler, then that's fine. But when you're documenting that the pulse, you needed a Doppler to get the pulse, then people are going to be concerned that this patient is having a perfusion issue when everything else is normal. But you could use it. It's not wrong.
Okay.
In any occasion, it's not wrong. It's not wrong in any occasion.
And how would you document it if you didn't use a Doppler? Would you just say amplitude of 0? Like how would you document that? Like you palpated the pulse, you couldn't actually palpate it, but everything else looked normal, like the color, the temperature, the movement, or would you just?
So I just haven't seen that happen, and that for that to be normal and for you just not to feel a pulse. But if that is the case, maybe the patient move up to the next pulse. If you have a pulse that's above the lower pulse, then you probably have good perfusion.
That's what I wanted to add, Ms. Cloud, too, that you're not going to document that you just don't have a pulse.
Right.
You're going to document that you either have a popliteal pulse and detail all of your additional perfusion parameters that you would assess, or but you would never detail a problem by saying a patient doesn't have a pulse. That's an emergency. So anytime, you never ever. So it's either going to be a palpable pulse in some other area, or it's going to be pulse per Doppler. I'm sorry, I just wanted to ring in on that. I know.
No, I appreciate it. This is going to be our perfusion instructor.
Well, and I know a lot of students, we tend to get caught in the traps of the what ifs. We can what if everything until a year from now, but we want to just make sure that we kind of understand that we have to look at what's going on with the patient's problem. Why are they there? What are we assessing? Because it can always change and it's always going to be individualized. But I think the biggest key to walk away with is understanding that we never, ever document unable to assess a pulse, period. Because then that's going to fall on you if something happens to that patient. Remember, no one's going to read your notes until something goes wrong. Okay. All right.
Right.
Thank you.
Thank you, Ms. Hanhart. So yes. Yeah, because I felt like we were going in circles and we're getting caught up in that pulse situation.
It's the what if. So remember, and you guys tend to trap yourselves in the what ifs when testing. When you're starting to add in the what ifs that's not in front of you on that question and it is not one of your answer options, then you're kind of ruining yourself when testing. So make sure that we always answer. We only take into consideration of what's in front of us, and then always, in relation to what's provided to us as an answer option. Once you start adding in stuff, then you're going to end up doing poorly on that exam. Okay.
I couldn't have said it better myself. Do not insert things and don't with the what ifs. Just take it for what it's worth. All right. Any other questions? No more pulse questions. So you want to check your peripheral nerve motor and sensory function. So your upper extremity nerves that you'll be assessing the function of is your radial nerve. And it kind of tells you how to assess your radial nerve. Also, you'll be assessing your median nerve and your ulnar nerve. So what situations will cause you to need to assess your median nerve?
Some type of injury to your hand?
Some type of injury to your hand. So just know how to assess these nerves. And it's all spelled out for you, the femoral, the lower extremities. What will cause you to assess the femoral nerve and the perineal nerve?
Spinal injury or leg injury.
Or leg.
Yep. So I would just advise you guys to know that. So go back and read that in a tibial. And just like Ms. Hanhart said, so I always try to tell patients to study, even though we don't have like disease processes in this lecture, go back and know what is the crackle, where is it heard, how do we treat it, what patients you'll see it in. And you do that for every exemplar when you go through your cardiovascular. Where are the, where we listen to the heart sound? Like make sure you know your landmarks. Remember, follow that SLO and make sure you know what's on that SLO. Where do we get these landmarks? Because anything on that SLO is testable. So know your landmarks for the cardiovascular system, know it for the respiratory system. And then when you start seeing abnormal symptoms of the cardiac symptoms, like what do you do when you see something abnormal? You have to assess, you have to treat. So if you go through every exemplar that we discussed today like that, what do we do for it? What does the tibial nerve assess? Everything, just go through it like that and you'll be prepared. If a patient has a respiratory issues, what do we do first? We kind of talked about that. They're lying flat, we got to sit them up. It just be simple as that, guys. And you'll get more in depth with these assessments when you go to perfusion, when you go to oxygenation, then you'll start putting medications with it and you'll start putting other diagnostic tests with it and they'll go through it. And you got 2 great instructors for all of these concepts. But if you have any questions about anything, please put it in the discussion board and we will try to get that answered for it. Well, we will get it answered for you. And also in the Canvas section, so if you want to know what kind of questions you may be asked, there was a putting it all together. Did you guys see that? So if you didn't see it, go back and review.
I seen it.
Good. So you can kind of get an idea of the kind of questions that could be asked, right? They had the rationales and they had questions. So, and if you have any other, go to your test taking skills with Ms. Leaf to get some. You want to start strong, and that's just the gist of it. You want to keep up and not have to catch up. You want to do well on every test. Like you don't want to wait till the end of the semester, like they said. trying to find points. When I went to nursing school, my auntie told me don't ever need a point. And I never needed one because I kept up. You have to keep up. So ask your questions now. They're all kind of resources. You have Ms. Schaff, you have Ms. Kemp, you have Ms. Leaf, you have your clinical instructors, you have all of your instructors. Don't wait till the end to look for assistance. Go to your SAC tutoring because sometimes your peers are your best teachers, right? So go to use all of your resources because we want you to be successful. We need nurses and we need competent, proficient nurses. So we want you guys to be successful. And if you have any questions, just feel free to ask. And thank you guys. And I think that is the gist of this class. Unless y'all have any other questions.
I don't know about anybody else, but that makes me feel a lot better.
Thank you. You did great.
Yeah, thank you so much.
That was a good class. Thank you very much.
I was very nervous, guys.
You made it very easy to understand.
You did great.
Yeah,
One more thing.